The committee will come to order. Today, our committee is honored to welcome Secretary Alex Azar to testify on President Trump's fiscal year 2019 budget proposals for the Department of Health and Human Services. Secretary Azar, congratulations on your recent confirmation, and thank you for being here today. We know you're only 2 weeks into this job, so we expect you to know everything. We are still reviewing the effects of the recent reforms and the budget caps adjustments that were included in last week's Bipartisan Budget Act, and we look forward to your testimony. Over the past year, our committee has been working to improve, strengthen, and streamline health care and welfare programs under our jurisdiction. In health care, we've taken action to cut needless red tape that makes it more difficult for providers to deliver high-quality care to their patients. We recently advanced targeted bipartisan reforms to improve Medicare for the American people, continuing the drive to strengthen quality and care coordination. And our committee played a first-hand role in developing comprehensive legislation to repeal and replace the Affordable Care Act. With the American Health Care Act that was passed by the House last May, we delivered market-oriented solutions that would truly increase flexibility, reduce costs, and return control of health care to the American people where it belongs. While this bill is stalled in the Senate, Congress has continued to deliver relief from Obamacare, including repealing the harmful effects of the individual mandate and the Independent Payment Advisory Board. We also took action to prevent several damaging health care taxes from going into effect. When it comes to the welfare and anti-poverty programs under our committee's jurisdiction, we've taken significant actions to strengthen families and communities and help more Americans move themselves out of poverty and into prosperity. We've advanced bills to improve America's child welfare system so that more of our kids can grow up in a safe home surrounded by a stable family. We reauthorized and then strengthened the maternal, infant, and early childhood home visiting program, an evidence-based program that provides real help to families in at-risk communities as they strive to build better lives. And we passed numerous bills to help more Americans get back to work. Several of these use the partnership and expertise of our local and state job creators to increase opportunities in on-the-job training for our American workers. I'm pleased that many of these important health care and welfare policies were signed into law as part of the Bipartisan Budget Act, but our committee is not going to stop there. Many Americans, including many of my constituents in Texas, are still struggling to access high-quality health care at an affordable price. Too many people across the nation are seeing their families torn apart by the opioid crisis. And too many Americans remain out of work, stuck on the sidelines of our economy, while our local companies struggle to fill job openings. This very issue is just reinforced by a new small business survey from the National Federation of Independent Business. Of all the small business owners who responded, over 1/5 cited the difficulty of finding qualified worker as their most important business problem. That was a larger percentage than any other issue in the survey. We have to find a way to bridge this divide. I'm convinced the best way to do that is by expecting and rewarding work in our welfare programs. We're pleased to see this same approach reflected in the President's budget request for HHS. On health care, our committees developed consensus solutions. We're eager to work with the Trump administration and you to build on them whenever possible. This includes taking actions to reduce the cost of prescription drugs, which I'm also pleased to see is a top priority in President Trump's budget. We know the Medicare Part D program has delivered good results for seniors and American families, and Republicans on this committee led that successful effort. We want to improve the program and expand access to affordable prescription drugs by working with you and the White House on a market-oriented approach that doesn't shift costs onto the backs of taxpayers. I believe the best path forward to help the American people is to continue to emphasize competition, new innovations, and individual choice rather than top-down mandates from Washington that interfere with efficiency and affordability. Secretary Azar, our nation faces a number of significant challenges in making our health care and our welfare systems work better and longer for the American people. Building off our committee's successful efforts and the family-focused priorities outlined in the President's budget, I'm confident we can work together to advance solutions that improve lives. Mr. Secretary, thank you again for being here today. We look forward to your testimony. And I now yield to the distinguished ranking member, Mr. Neal, for the purposes of his opening statement. Mr. Neal?
Thank you, Mr. Chairman, and certainly a word of welcome, Mr. Secretary. We look forward to your testimony, the first, I believe, that you will be offering to a congressional committee, and we're pleased that you're here. My goal, like the chairman noted, is to obviously advocate for the best possible opportunities for our constituents. That includes developing policies that help to create jobs, deliver high-quality, low-cost health care, and generally help all Americans make a better life for their families. The budget that President Trump has presented leans against these goals. Instead, it would create more obstacles for families to navigate as they try to make ends meet and move up the economic ladder. Last year, President Trump and our Republican colleagues rammed through a $2.3 trillion tax cut for the wealthiest and strongest among us. In his budget, the President now attempts to fill the deficit hole by slashing critical health and family programs instead of building on them to expand middle-class opportunities to move up. The budget sabotages health care programs by ripping the rug out from under the middle class and cuts the health care programs these hardworking Americans rely upon. Under the Trump budget, million more of Americans will lose their health insurance, and health care costs will continue then to increase. The Republican Trump budget attacks pre-existing condition protections by allowing companies to charge more for less coverage or to deny coverage altogether. It creates an age tax where seniors will be charged significantly more due to their age. For millions of Americans, this budget would cause their health care premiums to skyrocket. The Trump budget cuts $1.4 trillion from Medicaid and another $500 billion from Medicare. As more and more baby boomers enroll in Medicare, now is the time to strengthen and sustain the program, and we could have done that by adding critical benefits such as dental, vision, and hearing coverage, not to arbitrarily cut it. $1.4 trillion cuts in Medicaid will lead to cuts in health care for children, individuals with disabilities, and people who need long-term care. Medicaid, in our time in Congress, has now become a middle-class benefit. It's the reason that your parents aren't living in your attic, and it's a key component of the opioid and health treatment programs that we all wish to address. Medicare and Medicaid and other health programs are more important than ever as our nation struggles to find effective long-term solutions to the opioid crisis. Everyone in this room has a family member or knows someone who is directly impacted by an opiate or other drug-related disorder. Slashing programs that are designed to help those individuals is not the responsible path. Healthcare is a crucial part of the economy here in the United States. In my district alone, hospitals are the largest employers, and I must tell you with satisfaction and pride in Massachusetts, they are first-class citizens and first-class employers. Cuts to healthcare programs would offer significant job losses as proposed in this budget. The budget alone cuts more than $200 billion in payments to hospitals, threatening additional closures. This proposal would dismantle protections for struggling families and supports for Americans getting and keeping good jobs. The Trump budget cuts employment services for job seekers and employers, limits access to community colleges for trade-affected workers, and reduces the number of working families receiving assistance in many states. It makes no additional job training investments for workers who need to upgrade their skills, slashes Meals on Wheels, child and adult protective services, substance abuse programs, and other key programs by eliminating the Social Services Block Grant. These proposals directly undermine the fight against opiate abuse. It also proposes that Congress stop providing guaranteed multi-year funding for maternal, infant, and early childhood home visiting programs, which is currently authorized through 2023. Instead of focusing on giving the strongest and the wealthiest amongst us a $2 trillion cut in their taxes, we should be breaking down the obstacles so that middle-class families can indeed get ahead. And I yield back, Mr. Chairman.
Thank you, Mr. Neal. Today's sole witness is Alex Azar, Secretary of the U.S. Department of Health and Human Services. The committee's received your written statement, Mr. Secretary. It will be made part of the formal hearing record, and we've reserved 5 minutes to deliver your oral remarks. Secretary Azar, welcome, and you may begin when you're ready.
Well, thank you very much, Chairman Brady and Ranking Member Neal and members of the committee. Thank you very much for inviting me here to discuss the President's budget for the Department of Health and Human Services for fiscal year 2019. It's just a great honor to be here with you today, and I cannot tell you the honor of my life that it is to be able to serve as Secretary of Health and Human Services. HHS's mission is to enhance and protect the health and well-being of all Americans, and it's a vital one. And the President's budget clearly recognizes this fact. The budget makes significant strategic investments in HHS's work, boosting discretionary spending at the department by 11% in FY 2019 to $95.4 billion. Among other targeted investments that we are proposing, that is an increase of $747 million for the National Institutes of Health, a $473 million increase for the Food and Drug Administration, and a $157 million increase over 2018 funding for emergency preparedness across the department. The President's budget especially supports four particular priorities that we've laid out for the department, issues that the men and women of HHS are already hard at work on: fighting the opioid crisis, increasing the affordability and accessibility of health insurance, tackling the high price of prescription drugs, and using Medicare to move our health system to a more value-based direction. First, the President's budget brings a new level of commitment to fighting the crisis of opioid addiction and overdose that is stealing more than 100 American lives from us every single day. Under President Trump, HHS has already dispersed unprecedented resources to support access to addiction treatment. The budget would take this investment to $10 billion in a joint allocation to address the opioid epidemic and related mental health challenges. Recognizing that we need private sector and state-level innovation to defeat the epidemic, the budget supports HHS's work in disseminating best practices around prescribing, pain management, and addiction treatment, and invests $500 million to launch an NIH public-private partnership to develop new addiction treatments, new overdose-reversing drugs, and non-addictive approaches to pain. Second, we're committed to bringing down the skyrocketing cost of health insurance, especially in the individual and group markets, so more Americans can access quality, affordable health care. This budget recognizes that this will not be accomplished by a one-size-fits-all solution from Washington. It's going to require giving states room to experiment with models that work for them and allowing customers to purchase individualized plans that meet their needs. That's why the budget proposes a historic transfer of resources and authority from the federal government back to the states, empowering those who are closest to the people and can best determine their needs. The budget would also restore balance to the Medicaid program, fixing a structure that's driven runaway costs without a commensurate increase in quality. Third, prescription drug costs in our country are too high. President Trump recognizes this, I recognize this, and we're doing something about it. This budget has a raft of proposals to bring down drug prices, especially for seniors. In part, we are proposing a 5-part reform plan to further improve the already successful Medicare Part D prescription drug program to lower out-of-pocket costs for senior citizens. These major changes will straighten out incentives that too often serve program middlemen more than they do our seniors. These changes will save tens of billions of dollars for seniors over the next 10 years, adding to savings we are already generating with reforms to Medicare Part B under the 340B drug discount program. The budget also proposes further reforms in Medicaid and Medicare Part B to save patients money on drugs and provide strong support for FDA's efforts to spur innovation and competition in the generic drug markets. We want programs like Medicare and Medicaid to work for the people they serve. That means empowering patients and providers with the right incentives to pay for health and outcomes rather than procedures and sickness. Our fourth departmental priority is to use the tremendous power we have through Medicare as the largest purchaser of medical services in the U.S. to move our whole healthcare system in that direction. The budget takes steps toward that by, for instance, eliminating price variation on where post-acute care is delivered, rationalizing payments to physicians in hospital-owned outpatient facilities, supporting investments in telehealth, and advancing the work of accountable care organizations. The future of Medicare must be driven by value, quality, and outcomes, not the current thicket of opaque, unproductive incentives. The President's budget will help accomplish these three important goals at HHS. First, making the programs we run really work for the people they're meant to serve, including by making insurance affordable for all. Second, making sure that our programs are on a sound fiscal footing that will allow them to serve future generations too. And third, making the necessary investments to keep Americans safe from natural disasters and infectious threats. Making our programs work for today's Americans, sustaining them for future generations, and keeping our country safe is a sound vision for HHS, and I'm proud to support it. Thank you, Mr. Chairman.
Thank you, Mr. Secretary, for your testimony. And given the time constraints today, we will shorten question time 3 minutes. We'll now proceed, and I will lead off. So, Ms. Secretary, you made clear the priorities of President Trump's administration is making health care more affordable and higher quality, making sure our programs like Medicare work better and last longer, and addressing key issues like the opioid crisis. The Affordable Care Act remains in place. Congressional Republicans, we're committed to a smooth transition away from Obamacare's failures and toward more patient-centered care. So we're going to continue to look for targeted ways to increase market stability, to allow more choice for families, and provide relief for Americans who've seen their premiums double and their out-of-pocket costs skyrocket under the Affordable Care Act. Likewise, you have the opportunity through regulation and guidance to advance patient-centered health care from the executive branch. So can you briefly tell us what the administration has already done in proposals in the budget to ensure health care costs can come down, that we can lower health care premiums, and shore up some of the damage caused by the Affordable Care Act?
Thank you, Mr. Chairman. So one of the things that we've been doing is looking for flexibility and state partners where we can help them with designing alternative programs here under the Affordable Care Act that can help deliver services to their people. For instance, the Alaska waiver that created a reinsurance pool, allowing higher cost individuals to be pulled off into a funded high-risk pool and saving money for all the other individuals in that pool. We continue to look for state partners that want to be innovative and want to try different solutions. I think, when we're talking about health insurance, there's no one-size-fits-all. There's no magic bullet, no single right way to orchestrate a competitive, well-run risk pool insurance system, and that's why I look forward to working with states under our proposal or whatever Congress happens to pass to work with states to develop systems that work for people and make insurance more affordable. We all share the goal. We want folks to have access to affordable health insurance.
Absolutely. Mr. Secretary, on that second priority, making programs like Medicare work better and last longer, I noted on the Affordable Care Act, Medicare was slashed by over $700 billion, a huge hit to that important program. While tax reform, because it gets more people back to work, and we're now starting to see wages go up, that's one of the key funding mechanisms for Medicare, so we expect that to be helpful. Let me ask you this. Under the budget proposal, while we hear a lot of draconian claims, is it accurate that Medicare continues to grow under the Trump budget at over an 8% annual growth, and that your proposals actually extend the life of that important program? Can you elaborate?
Absolutely, Mr. Chairman. So we're making some common sense changes in Medicare to how we do our payments with providers and how we're organized. These are things that do not impact the beneficiary. They retain the benefits beneficiaries have, don't change the cost sharing for the beneficiaries. If anything, we help them with cost sharing. By making these changes, overall net to the Medicare program, we are only reducing spending over 10 years by about $250 billion. That is a 2.3% change from the current baseline amount of spending. To give you a sense of perspective, currently Medicare will grow on an annual basis over 10 years 9.1% each year. With our proposed changes, it will grow 8.5% each year. And we gain 8 years of additional life of the Medicare program as a result of these modest but important changes to it.
Thank you, Mr. Secretary. Mr. Neal, you're recognized.
Thank you, Mr. Chairman. Mr. Secretary, the overall budget framework, which sinks the nation into deficits that will near $1 trillion a year, or recently estimated $7 trillion over the next 10 years. Certainly, Republicans have moved away from what they used to say about balanced budgets. In addition, they decide that they are going to make cuts to very important initiatives that many people here in America have come to rely upon. And they are, despite what is being said, making cuts to Medicare. Overall, the budget proposes more than $500 billion, $532 billion in cuts to Medicare over 10 years. $200 billion alone to our hospitals. These hospitals are the cornerstones of many of our communities, and cuts of this magnitude will result in hospitals closing and losing jobs. A reminder for virtually every member of this committee, as well as the members of Congress, the hospitals have now become the biggest employers, and as I noted earlier, in Massachusetts, first-class health care. The budget proposes another $80 billion in cuts to post-acute providers that treat Medicare beneficiaries who are the most frail and vulnerable, and another $16 billion in cuts to home health care agencies through administrative actions. I don't believe that these cuts are tied to improving efficiency or increasing quality. In fact, I believe these cuts could jeopardize quality health care for many Medicare beneficiaries. All of this is done based upon the idea that we could cut taxes by $1.5 trillion immediately, but when you consider the cost of borrowing that money, $2.3 trillion over 10 years, with the Federal Reserve Board promising that they intend to raise interest rates by at least 3 opportunities and maybe 4 or 5. The administration is promoting these draconian cuts with another $1.4 trillion cut to Medicaid. A reminder, as I noted in my opening statement, Medicaid now is long-term care in America. It's for our seniors, it's for nursing home care, and these proposals, again, were done on the basis of justifying a tax cut for people at the very top and who are the very strongest. Mr. Secretary, I ask you to reconsider these cuts going forward. The health of our providers and communities depend on us being prudent and not rash. And I hope you can address the issue of graduate medical education as well as to what's proposed there. As you know, that's a big employer for many of us, particularly concentration in big cities across the country. So if you could speak to those issues and address the issue of cuts to Medicaid and nursing home care, that would be most helpful.
So, Ranking Member Neal, first, I very much look forward to getting the chance to sit with you and working with you in the years ahead. So, thank you very much for that opportunity. In terms of graduate medical education, what we're proposing there is to unify. We have various streams of graduate medical education right now for training doctors. They're frozen in place as of 1996. We're proposing to pull that together and give us the flexibility so we can actually train doctors that are focused on underserved specialties and underserved areas. So that's the thesis that we're working from.
Thank you, Mr. Secretary.
Thank you, Mr. Neal. So, 45 years ago, Colonel Sam Johnson returned to America after 7 years as a POW in Vietnam. Every year we honor what we call the return anniversary of Sam Johnson. Sam, before I recognize you, on behalf of our committee and everyone in this room, welcome home yet again. Thank you for your service.
God bless you all. All I can say is it's a hell of a lot better being in the United States than in Korea. Mr. Secretary, welcome. I'm sure you know Obamacare included an effective ban on the expansion of physician-owned hospitals, as well as a ban on the construction of new hospitals. What this means is that Obamacare prevents some of our best hospitals from expanding to better serve our communities, such as those in my fast-growing district, and I believe that's wrong. Mr. Secretary, would you agree that this ban limits competition in the hospital sector, yes or no?
Yes, Congressman Johnson, I do believe physician-owned hospitals can provide effective competition for other hospitals.
Would you agree also that some of the best quality hospitals are physician-owned?
Yes, it's my understanding that many physician-owned hospitals deliver superb quality care, and we ought to be inspiring competition among providers.
Finally, will you and the administration commit to working with me on repealing the ban as we know it?
So I commit to working with you on any changes that we can make to ensure that we're allowing good competition, allowing physician-owned or other-owned facilities to compete and deliver the highest quality, lowest cost service to our beneficiaries. So I'm very happy to work with you.
Thank you. Having said that, all of the hospitals in this nation are better than what I saw in Vietnam. Thank you very much.
Thank you, Mr. Johnson. Mr. Levin, you're recognized.
Well, special hello, Sam. A special hello. We've all welcomed serving with you. Mr. Secretary, we also appreciate the way you've been reaching out, and we thank you. You said no one size fits all. That was the line for decades. And the problem was that the alternative was that any size at all will fit. And you now have a request, I think, for a waiver, or you're reviewing the Idaho health proposal that would allow premium rates to be tied to pre-existing conditions, I think in violation of ACA. Are you reviewing that?
So Congressman Levin, first, thank you very much for our phone call. It meant a great deal to me, and I look forward to working with you. On the Idaho situation, I am not aware of a waiver request. I have seen the media reports about the interactions between the government of Idaho and one plan, but I'm not aware that our opinions or views have been solicited on that question yet.
Will you look at it?
We will look at that when
Okay.
whenever it comes to us. Of course, there are rules, and there's a rule of law that we need to enforce.
All right, let me ask you about, thank you, the elimination of programs in the President's budget, which we've discussed. I want to start with LIHEAP. Have you ever known anybody who benefited from the LIHEAP program?
I have not personally, Congressman.
What are people going to do? It eliminates $3 billion in assistance. What are those hundreds of thousands of people going to do if that's eliminated?
So, Congressman, with the LIHEAP program, where we provide grants out to states that they could then provide to individuals, one of the challenges we have there is it's a very large program, $3.4 billion in a limited fiscal environment. The challenge we have with budgeting is if we were to restore funding for LIHEAP, we have to take from somewhere else, and so it's the tough choices of prioritization. We believe the LIHEAP program is duplicative of many state and local and utility protections for individuals, especially in the cold season.
Okay, so let me just interrupt.
Losing their electricity.
Because, let me, if I might, I have only 25 seconds. I can say it in 25 seconds. Essentially what you're saying is because the Republican approach has so increased the deficit that you have to reach elsewhere for money. The deficit's been increased trillions of dollars, and now LIHEAP is a victim with hundreds of thousands of people. I urge you reconsider. Thank you.
Thank you. Mr. Reichert, you recognized, I would note, too, that during President Obama's term, Democrats raised the national debt $2 trillion in 1 year. Mr. Reichert, you're recognized.
Thank you, Mr. Chairman. Mr. Secretary, congratulations on your new position. As a grandfather of two amazing grandchildren who were born drug addicted but who are thriving today, I want to thank you for your commitment to addressing the opioid epidemic. Mr. Secretary, just not too long ago this morning, I was able to tell you personally that I'm on a mission. I'm on a mission to help patients suffering from lymphatic system failure. While associated with 40 different diseases, it most commonly acquired secondary cancer due to the damage caused to the body's lymph nodes and autoimmune functions. There is no cure. There's no cure, but there is hope. And that comes in the form of compression garments, really, and some other little treatments that go along with that. Compression garments replace all or part of the function of the lymphatic system, and sadly, Medicare does not cover these items, leaving millions of patients without access to the care they need. The Veterans Affairs Department, TRICARE, and 42 states in the District of Columbia cover lymphedema compression supplies. My efforts and 362 other House and Senate co-sponsors of the Lymphedema Treatment Act, including the majority of this committee, and Mr. Blumenauer, who leads the bill with me, feel strongly about helping Medicare beneficiaries manage this chronic disease. I was encouraged by your Senate confirmation hearing because it is clear you get it. I could not agree more with you that too often we can be penny wise and pound foolish. We say we won't cover something because it doesn't fit in a category, even though we know it improves patients' health and ultimately saves Medicare money by reducing hospitalizations and other costly medical complications. This certainly fits within one of your stated goals. Medicare value-based system is what you're seeking to accomplish. In 2001, CMS put out a statement, the keystones of lymphedema, and I quote, lymphedema treatment are elevation, compression, and exercise. Encourage patients to use compression garments between pump sessions to prevent reaccumulation of fluid. Despite this statement in 2001, 17 years ago, there is still no solution. Mr. Secretary, I am just asking you, please, after 6 years of working on this myself, a commitment from you is needed by the people who are watching today, live streaming this hearing. A commitment from you to help them solve this problem. Please.
So, Congressman Reichert, I will work with you to see if we can solve this, and certainly if it's a legislative fix, work with you to provide any technical assistance. Absolutely.
Thank you.
Thank you. Mr. Lewis, you're recognized.
Thank you, Mr. Chairman. Mr. Secretary, thank you for being here today. Less than a year ago, your predecessor, a former member of this committee, sat in that very chair and defended a budget that broke every promise to the sick, the elderly, and working families. Last year, I thought the administration budget was mean and spiteful as it tried to balance the budget on the back of the sick, the elderly, and working family. I hope and pray that members of this administration will search their soul. Instead, you propose yet another budget that help a select few, or put a select few ahead of the good of all of our citizens. Instead, you target those struggling to find food to eat, to keep a roof over their heads and heat in their homes. Instead, you attempt to balance the budget on the back of those living paycheck to paycheck. Once again, this budget strikes fear in the hearts of those who rely on Medicaid. Once again, this budget slashes billions from Social Security. Once again, this budget seeks to dismantle the social safety net. That is not right, it is not fair, and it's not just. Every person watching at home should understand that this budget is dangerous and unrealistic. Mr. Secretary, people across the country expect their elected representative to call it as it is, to speak truth to power. History will ignore those, history will not ignore those who try to pretend that this is normal. History will not be kind to those who are quiet in this moment or in this time. Mr. Secretary, I think you know deep that this budget is an affront to the dignity and the well-being of the average American. In my estimation, it is a shame and it is a disgrace. I think we can do better. I'd like to ask, in the 5th District of Georgia, can you find a person to appoint as the head of CDC?
We have not yet identified a candidate to run CDC, but I will tell you I am just delighted that we have such an amazing career professional in Ann Schuchat, who is so respected globally as in the world of infectious disease and epidemiology. We as a country are so fortunate to have career professionals like Dr. Schuchat.
Well, thank you, Mr. Secretary.
Thank you, Mr. Lewis. Mr. Roscom, you're recognized, Chairman of the Health Subcommittee.
Thank you, Mr. Chairman. Mr. Secretary, we spoke briefly yesterday about some of the fraud issues, and I just want to direct your attention, and I know you've got a background in this. The fraud and erroneous payment rate is unacceptable, so let's take error and set that aside, and let's take the enforcement issue and set that aside as well. Can you focus in on predictive modeling, that is the algorithms that get created to make sure that the money doesn't go out the door at the front end. I know you've got a strong background in this. I think that this is an area where there shouldn't be a division among us on a partisan basis, and I think we've done good work on this in the past, but there is a lot of money that can be saved here, and I'd be very grateful for your guidance and your insight, and particularly your initiative. So set aside error, set aside enforcement just for the purposes of this question, and focus in on predictive modeling.
Absolutely, Congressman. So this is an area of actually great passion of mine also, and as well as background. I believe that we can use the very rich pools of data that CMS has access to and apply to it interoperable data sets that we then can apply predictive modeling to look basically for where are trends just out of whack, where is something wrong that isn't fitting, that isn't like the rest. And that can enable us to identify outliers and save so much money. And every penny that we save is another penny that we can devote towards benefits for our seniors or extending the life of our program. So this is something Administrator Verma and I have already talked about. We hope to keep making investments in this IT infrastructure and working with individuals who have the skill set to do exactly what you're talking about.
I'm pleased to hear that. So there's when I chaired the Oversight Subcommittee, along with Mr. Lewis as my ranking member, we brought in CMS to give us their fraud and erroneous payment number. They said it was 12.7%. Again, fraud and error, there's a distinction there. Part of the challenge, though, they couldn't distinguish between fraud and error, but I set that aside. Then just to create a sense of wonder and awe and just jaw-slacking mystery, we brought in the person who's in charge of Visa and asked them the same question, what's your fraud and erroneous payment rate? And he said, my recollection is on $10 trillion that went on that system annually, it was 0.06%. So this is going to take executive leadership. There's a role for us to play, but you know how big institutions work, and particularly the institution that you're now leading. I just want to encourage you to be tenacious, and I think that you will find willing partners here on a bipartisan basis to join with you from a legislative point of view to get this done. I yield back.
Thank you, Mr. Chairman. Mr. Dogg, you're recognized.
Thank you, Mr. Secretary. Let me ask you to respond in writing to the following specific questions. As you know, last year President Trump said that Big Pharma was essentially committing murder. He also said, quote, we have to create new bidding procedures for the drug industry because they're getting away with murder. We're the largest buyer of drugs in the world, and yet we don't bid properly. We're going to start bidding. We're going to save billions of dollars, end quote. Of course, the administration has not begun any bidding. It has done nothing to bring down the spiraling cost of prescription drugs. I would ask you the same questions that I asked your predecessor, and your staff can turn to his answers as an excellent example of avoiding a real answer and dodging the question. Whether you can confirm that the administration has abandoned President Trump's promise to have Medicare price negotiation and to support the safe drug importation to allow a little competition to bring down prices. Two questions that I'll put in the same words that I sent to Mr. Price that he refused to directly answer. Secondly, instead of addressing the murder, President Trump in his budget proposes to reward the murderers. I want to ask you about President Trump's plan to hike prescription drug premiums for every Part D person on Medicare, and whether or not it isn't true that while you pretend to lower the cost for some, that Medicare has already estimated that premiums will rise as much as $44 per month for every Part D recipient because of the change you plan to make in the way Medicare rebates are done, and that this plan will simply put more money in the pockets of Big Pharma and cost taxpayers and Part D recipients more. Next question concerns opioids. As you know, 41 attorneys generals have conducted an investigation of the role that pharma played in causing the opioid crisis. Hundreds of localities have brought legal action against pharma. You know that Medicare covers nearly 4 in 10 non-elderly adults with an opioid addiction, and in 2013, Medicaid spent $9.4 billion for their care. My question is, can you report to us on what this administration has done to investigate the role of pharmaceutical manufacturers, and when can we expect the administration to bring legal action against these pharmaceutical companies for their role in creating this problem and stop billing it all to the taxpayer? Finally, for today, sir, would you answer as to whether you will commit to provide the information required by law on non-bid contracts that HHS has entered, which HHS has refused to provide in accord with law throughout 2017 and into this year, so that we know on contracts and grants what no-bid contracts
Thank you.
your
The
department
gentleman's time has expired.
Can you
Mr.
answer on that?
Secretary, since the time has expired, if you'd respond to Mr. Doggett in writing, that'd be perfect. Thank you, sir. So, Mr. Smith, Chairman Smith, you're recognized.
Thank you, Mr. Chairman. Thank you, Mr. Secretary, for being here and sharing your time. Several topics to address here, so I'll try to make it quick. My district has 55 critical access hospitals. That's still fewer than one per county in the 3rd District of Nebraska, but the beauty of the system is, even though there's a singular designation, there's no two alike in terms of what they do or how they meet the community needs. And so I hope that we can work together on regulatory relief. I know that your department has been working on that. I appreciate the administration's commitment to that, including making the 96-hour enforcement a low priority for contractors. And like I said, look forward to working with you on that. Now, I do want to touch briefly. Last year when we had this hearing, I submitted a question for the record relating to the Bay State boondoggle. Did not receive a response. So could we I guess, work to get more information on the Bay State boondoggle in that reimbursement formula that I think is clearly broken and really takes resources away from hospitals in so many states across the country.
I'm not familiar with the issue, but I will ensure that we get you a response on that. I'm sorry you haven't heard back yet.
Sure, appreciate that. Another issue that I hear a lot about recently is the deeming of competitively bid prices on for durable medical equipment in non-metropolitan areas, and particularly whether the deemed reimbursement levels are sustainable for providing appropriate service in rural and remote areas. And can you tell me whether CMS compared these reimbursements to the cost of actual delivery of DME in rural areas when making this decision? And wondered if you might be able to, maybe not today, but to get information for me later on.
So I am very concerned about ensuring that our competitive durable medical equipment program works well, especially in rural areas. In the budget proposal, actually, we have ideas there around how to make that work better for rurals, to ensure that rurals are competed and the pricing in the rural area is based on rural providers, and also the bid that the winner gets is their bid, not just a median price. So I'd love to work with you. We want to make this work for rural providers and rural citizens.
All right, I appreciate that. One more topic is the McVie program, the Maternal, Infant, and Early Childhood Home Visiting Program. Very successful program, has bipartisan support, and part of it is because of the benchmarks that are used that can be chosen to focus on improvements on family economic self-sufficiency. And the previous administration decided to define economic self-sufficiency as being in school or having health insurance, and not really looking at the employment and wages. And so I was wondering if you might be willing to work with us as we do try to accurately reflect self-sufficiency. Thank you. I yield back.
Thank you. Mr. Thompson, you recognize.
Thank you, Mr. Chairman. Mr. Secretary, congratulations on your new post, and thank you for being here today with us. I'm concerned about the $1.4 trillion cuts to the Medicaid program, and just want to point out that those don't just hurt low-income families. Those cuts hurt state budgets. They jeopardize other priorities like education and infrastructure. They undermine our health infrastructure, and they're limiting our ability to respond to nationwide epidemics such as the opioid crisis. This proposal also grows our debt. So we're going to end up getting less service for the people that we represent and work hard across this country, and the reward's going to be we're going to have a much bigger debt. I don't agree with this administration on these cuts, nor the damage that this proposal is going to do to our Medicare program. But I looked hard to try and find some areas of agreement. And one thing that I did like was the fact that during your confirmation, you responded, I believe, positively to senators inquiring regarding your view to telehealth. Matter of fact, I think you called yourself, quote, a big supporter of telehealth and alternative means for providing health care. Instead, that you're really looking forward to working with Congress on expanding telemedicine to meet the needs of rural and underserved communities. This is a big priority of mine. I've worked on this forever and was successful way back in 1990s in California, being able to incorporate telehealth into the Medi-Cal program in California. Saved a lot of money, and more important, it saved a lot of lives. So I'd like to know, are there specific areas of promise that you see, or areas that you support in telehealth where we can together focus our energies?
So, Congressman Thompson, thank you for that, and I would love to work together with you and get, you're right, you, I'm sure, know more about this than I do in terms of concrete areas where we can help and enable telehealth. We have some provisions in the budget that we're proposing around Medicare Advantage and some other areas that will further enable telehealth, but I'd love to sit with you or get any suggestions you have how we can enable further.
Thank you. I appreciate that. And I just want to say, and you can respond in writing on this, that before you arrived at HHS, the administration finalized a rule to cut more than $1.5 billion from our safety net hospitals participating in the 340B program. The rule, I believe, is seriously misguided, and it hurts our hospitals that are big employers and provide critical services. It's bad for jobs, it's bad for our economy, and it's bad for the people that depend upon those services. And I'd like an opportunity to work with you to see if we can't figure out a better solution. Thank you.
Thank you, Mr. Jenkins. Chairman Jenkins, you're recognized.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here today. We recognize as well as appreciate this administration's fight against unnecessary and burdensome regulations in the Medicare space. I represent a large rural district in eastern Kansas where care options can be limited, and addressing any harmful government regulations are crucial as small rural hospitals work to provide care in underserved populations. Can you talk about any plans that you may have to reduce the burdens placed on providers over the last few years, particularly to rural providers such as our small group physician practices and rural hospitals?
You bet. Thank you very much. And we share the concern about care and underservice in the rural environment. Last year, actually, CMS launched a program called Patients Over Paperwork Initiative, which was a collaborative process that tried to evaluate ways in which our regulations or our practices were impeding physicians or providers delivering care to individuals unnecessarily. And so as part of that initiative, CMS actually reinstated non-enforcement of the direct supervision requirements for outpatient therapeutic services for our critical access hospitals and small rural hospitals having 100 or fewer beds for calendar years 18 and 19. And I'd look forward to working with you on that and other initiatives to help our rural providers be sustainable and deliver service.
Perfect. I'll look forward to that. As a result of a flawed CMS regulation, hospital-based nursing schools have been put in the impossible position of deciding between losing their school's accreditation or preserving vital funding. I've authored legislation which is a common sense solution to this regulation and will ensure that our nation's hospital-based nursing programs can continue providing high-quality nursing professionals to our communities. Will there be movement on relieving this burden for those hospital-based nursing programs placed on them from the federal Medicare Nursing School pass-through funding program administered by CMS?
So as the son of a nurse, I'm obviously concerned about this issue, but it's the first I'm hearing about this, and I'd look forward to learning more from you about that and also working to see if it's something that we can solve.
Okay, great. The bill is H.R. 662. It's called the MEND Act, and we'll be in touch with you. We'd love to work with you. Thank you so much. Thank you. Mr. Chairman, I yield back.
Thank you. Mr. Blumenauer, you're recognized.
Thank you, Mr. Chairman. Mr. Secretary, you had an example of sort of the alternative universe that much of our debate is centered. My friend, the chairman, talked about a trillion or $2 trillion deficit under President Obama, who inherited an economy in free fall, and the Recovery Act actually put people to work. It had infrastructure, it had research, and it had tax cuts for the bottom 80%. Now we have a situation where the economy is strong, yet we are cutting taxes for people who, in the main, don't need it. They're getting most of that benefit. And we're looking at trillion-dollar deficits as far as the eye can see. Such a reversal from my friends on the Republican side. But we don't have to spin up everything in fighting some of these last battles and trying to remind each other of facts. Or have an ongoing arm wrestling contest about blowing up the Affordable Care Act. One of the things that I appreciated in your testimony during your confirmation was reference to being sensitive to the needs of American families facing challenges at end of life. And what can we do to be able to strengthen the protections to make sure they get the care they want? We made some progress. It was more trouble than I thought with the last administration. We're moving some things forward. My good friend, Dr. Rowe, and I have bipartisan legislation that's been broadly supported, H.R. 2797. And I would hope that there would be a way to be able to work with you to drill down, to deal with making sure that we advance models, like in our legislation, to make sure that patients, all patients, have timely access to palliative and hospice care, and to be able to have progress dealing with quality measurement to make sure that we are monitoring what is in fact happening and that we have confidence in that.
Well, Congressman, thank you for your work in that area. I share your goals there. I want to ensure that individuals who are facing end of life can do so and approach it with dignity, and that we're helping them in the setting that they wish to be in, and also that they can face the issues that they're facing with as much clarity for family members and others about their own desires and plans as possible. So look forward to working with you in this area.
Great. I would appreciate the opportunity to refine that, to be able to make sure that their wishes are honored, that they follow them in an era of electronic medical records. I think there's a lot of bipartisan opportunity to get more out of the system, and look forward to working with you on it. Thank you very much. Thank you, Mr. Chair.
Thank you, Mr. Blumenauer. Mr. Paulson, you're recognized.
Thank you, Mr. Secretary, also for being here this morning. As you well know, more Americans now are dying of drug overdoses than died from AIDS at the height of the HIV epidemic more than 20 years ago, and opioid abuse is the main reason why. And obviously, as the new secretary now at HHS, you're helping lead the government's efforts to stop the spread of opioid addiction, and it's an enormous challenge. You have my full support, you have our full support. And as you refine and now execute an opioid strategy, I would encourage you to also prioritize non-opioid alternatives for providers to help treat patients who are suffering from chronic and acute pain. We had a recent Ways and Means Healthcare Subcommittee hearing on the opioid crisis, where we discussed innovation and minimally invasive medical devices that are FDA approved, that are reimbursed by CMS, and are proven to reduce addiction and pain, but they're prescribed much less than opioids. And the FDA commissioner also testified that the FDA has approved more than 200 different medical devices to treat pain, but a lot of these patients are being denied access to these therapies, either because of restrictive CMS coverage or maybe payment policies. So, as you mentioned earlier, the budget calls for increased funding that will help states fight this epidemic, but are there payment incentives in that budget request that you know of or that can think of that Medicare and Medicaid will be able to use to help promote evidence-based care for beneficiaries with chronic pain that will help reduce the risk of developing an opioid addiction?
So we have much in the budget, obviously, about the opioid crisis. The issue of CMS payment incentives around it is an important one. I'd love to get any insights you have, either on any ways in which you think we could do incentives to drive away from opioid treatment for pain. The other would be, I'd love to learn more about the barriers on any of the reimbursement on non-opioid treatment that we've got. That's a major area of focus. We're putting $750 million in this budget over at NIH simply to keep working on the non-opioid pathways for pain treatment. So I'd love to make sure we're removing any barriers in our own department to that also.
That'd be great if you'd be willing to work with us, and I can stay in touch with your operation about those alternative therapies for chronic pain. There are barriers that exist in Medicare and Medicaid, so I appreciate that, Mr. Secretary.
Thank you.
I yield back, Mr. Chairman.
Thank you, Mr. Paulson. Mr. Kind, you're recognized.
Thank you, Mr. Chairman. Secretary Azar, thank you for coming today. Hopefully this is the beginning of a very constructive working relationship between you and this committee, and 3 minutes isn't a lot of time, so let me throw a few issues that are paramount on my mind. I come from a large rural western Wisconsin district. Rural health care is obviously very, very important. And yet, my constituents would certainly be concerned with the $2 trillion of proposed cuts that we're seeing right now in the administration's budget affecting Medicaid and Medicare funding. You know, in the last 8 years, we've lost 83 rural hospitals. There are over 700 that are listed on the very vulnerable list right now. They're all operating on a very thin margin. And those type of cuts, especially given a population that's very Medicare dependent, could mean life or death to many of these rural providers. I'm looking at Ms. Sewell here, and there are others on the committee that have equal concerns when it comes to. So I encourage you to work with the Rural Healthcare Caucus that we've established in the House. Myself and Kathy McMorris-Rogers are co-chairing that, so as we bring issues to you that you'll give it due consideration. But I also want you to keep an eye on Indian Health, very important programs. I come from Indian country myself, too, and work very closely with them. That's another important area of jurisdiction. And then for me, when it comes to healthcare reform, hopefully, with your help and leadership, we can get out of this box of ACA and no ACA and start focusing on what's working and what isn't in the healthcare system. And one thing that I see working in my own backyard are healthcare providers with wonderful models of care. I'm talking about the Gundersons, the Mayos, the Marshfields, the Aurora, the Theta Cares that go to an integrated, more coordinated, more patient-centered healthcare model, producing great results, embracing that type of model where we need to drive the healthcare system today, but also embracing something that is in the Affordable Care Act, and it's the move to value, to quality, to establishing the payment system based on results and not just doing more. I think that is so fundamental if we're going to get our hands around the rising costs of healthcare in our country and getting to better models of care that produce better results at a better price. And there's an institution that was created in the Affordable Care Act to help us with alternative payment models, the Center on Innovation. Unfortunately, that's come under attack, some partisan attack, I think, unjustly, but they're going forward with pilots and experimentation, finding out what will work, what incentives need to be there to encourage the providers to get the outcomes and quality and away from fee-for-service, just more payments regardless of the results. So I hope that you embrace the Center on Innovation and the good work that they're doing there. Certainly, you know, reforms and modifications are in order, but there is, contrary to a lot of the political rhetoric, a lot of important things in the Affordable Care Act that will be crucial to getting us to a better outcome and a better payment system within the health. And also, being from the drug industry yourself, hopefully you're going to be able to provide insight on what we can do working together to address the rising cost of prescription drugs, which is one of the main cost drivers in the healthcare system. So we look forward to working with you in the future. Thank you, Mr. Chairman.
Thank you, Mr. Kind. Mr. Martin, you're recognized.
Thank you, Mr. Chairman. Secretary, I represent a managerial type district around the DFW airport, about 15 communities. Most of the constituents are working in those corporations or businesses around the airport. When I have a town hall meeting, the first question I ask is, how many of you receive a service from the government? How many of you receive a check? And well over half always raise their hand. And then at the end of the day, most of those people are on Medicare Advantage. So they're getting very good health care, and there are a few complaints about the quality of the health care. But the question I always get is, and the assurance I always give them, is that that level of care is going to continue, that the Medicare system will stay solvent, and the federal government, through innovation, will with less money, achieve the same levels of care that they're receiving now. Now I get to ask you to speak to them and assure them of what I'm telling them is true.
Absolutely. The deep commitment to Medicare, and especially the Medicare Advantage program, which 40% of our seniors are now enrolled in, and the majority of aging-in seniors are choosing Medicare Advantage. We want to make sure that that works for people and delivers high-quality, low-cost care for seniors. You know, part of my job is to make sure that this program, which is such a bedrock of our society, remains solvent. And that is by taking waste, fraud, and abuse out of that system, by the transformation to value. How can we pay more for outcomes and value? So instead of paying for sickness, pay for good outcomes. So all of that is with an eye towards the more money we can save and the higher quality outcomes we deliver, the better we're going to serve your constituents that are talking to you about these programs, and keep it there for them in the future.
Thank you, Mr. Chairman.
Thank you, Mr. Martin. I should note, as we began the discussion, I failed to mention two important things. One, I want to welcome Representative LaHood, who was just here a moment ago, to his first, thank you, Mr. LaHood, who won't sit in his seat. Welcome to the committee. We're glad to have you. You jumped in so quickly to the committee's work, I forgot to welcome you to the Ways and Means Committee. Thank you, Mr. Hood. And I also forgot it's the birthday of our esteemed ranking member, Mr. Neal. Happy birthday, Mr. Neal. Welcome to all that you do. Well done, sir. Yeah. So, Mr. Pascrell.
Thank you, Mr. Chairman. Mr. Secretary, you've had a splendid reputation for listening in your job, but this is not business, this is government. Very different. So welcome to the combat zone. I have a couple of questions. You know, we've hurt hungry families in the proposed budget, which cuts that budget by the SNAP program by $214 billion. There is a relationship between nutrition and health, and I don't have to go into those specific details. And then the rest of the budget cuts $1.4 trillion from Medicaid, which is the very basis of any states helping opiate victims and trying to prevent it and trying to respond to those. It eliminates and cuts spending in Medicare by $494 billion. So good luck to you. You have to defend this stuff, but from your reputation, you could rise above this. I hope that happens. I want to talk about the HIV/AIDS program. It's very close to me for 30 years of my life, working with people who at first no one wanted to work with, and secondly, to get the federal government to understand its responsibilities. This administration, I personally believe, has abandoned people living with HIV. It wasn't enough that the president had to shut down the Presidential Advisory Council on HIV/AIDS and close the White House Office of National AIDS Policy, but it's also attempting to gut funding for HIV prevention, cure, and treatment. This budget could close the door in the face of all progress that has been made under Democratic and Republican presidents to curb this horrible disease, both here in America, abroad, and turn the clock back to the 1980s. We don't want that to happen. I know you don't. So, Mr. Secretary, please explain the rationale behind the domestic cuts to HIV/AIDS funding, and specifically the $43 million in cuts to the Ryan White program. Mr. Secretary.
So, Congressman, the Ryan White, we strongly support the Ryan White program and have kept, it's a very large program, and I can't remember the exact numbers on where it's come out, but it has the Ryan White HIV/AIDS program has our full support and backing, as do so many of the initiatives around.
How do you explain these cuts?
So we've got the support.
Which are being proposed.
And then we have in PEPFAR continued support abroad on HIV/AIDS. So I'd love to work with you I want to make sure to understand across the board, as the chairman mentioned, I'm still getting into the details of so many of our programs and where they stand currently from 10 years ago.
My point being, Mr. Secretary, I'm interested in what you're for. I'm interested in how you will fight these cuts, because you have a bigger responsibility than the President of the United States in dealing with those people afflicted and those people who might be afflicted.
Thank you, Mr. Pascal. Time has expired, and as usual, we'll move now to 2-to-1 questioning so we can balance out the hearing. Chairman Black, you're recognized.
Thank you, Mr. Chairman, and welcome, Mr. Secretary. I really appreciate you being here. I'm going to go in a little different direction about something that really does affect the state of Tennessee, and in particular our rural hospitals, but all hospitals across the entire state are affected by the area wage index. And this is something that I've been working on now for, I guess, at least 6, 7, maybe 8 years, is to try to get some parity, because our hospitals are not being treated fairly. As a matter of fact, the formula was intended to reflect a 1.0 average rate. There is not a single hospital in all of Tennessee that gets that rate. So our hospitals are down below 0.7 in many cases, and especially rural hospitals, this is very damaging to them. They may not be able to stay open unless we do something. Do you see a path forward with taking a look at this and trying to get some parity?
So, Congressman Black, thank you for raising that issue. I suspect that if we polled all the members of the committee, that nobody would be satisfied with the wage index. There are often so many undesirable outcomes for our providers in that, and being budget neutral, unfortunately, every time there's a change, winners and losers there. Obviously, want to work with you and the Congress if there are any legislative changes around the wage index or administrative that we can do that make things more equitable. I certainly understand the concerns that you have there and understand that they have real impact on our providers.
I would point you to what MedPAC has done over the last several years in their recommendations. They have looked at this. They acknowledge that it needs to be addressed. And I think that now that you're the new secretary, I would really like for you to take a look at this and have your staff spend a little time and get back to me on what their thoughts are.
Will do.
Finally, I only have 1 minute. I want to applaud you and the administration on looking at mental illness. It is a huge issue. As I travel throughout my state and I talk to law enforcement, anywhere between 20 and 40% of the inmates have mental illness, and that's because they're in the jail because there aren't other services for them. And we really must address this, so I applaud you for the amount of money that is being put into this and also the creative way of thinking about treating people with mental illness. That we closed hospitals down in the 1970s when I was a young nurse, and we said it was better to put them in the community, but we didn't have community services. We now see them laying on benches without something to eat out in freezing cold weather, and we have got to do something about making sure we take care of our mentally ill. So thank you for that, and I yield back the balance of my time.
Thank you, Chairman. Mr. Reed, welcome to the top dais. You're recognized.
Thank you, Mr. Chairman. The altitude up here is much higher. I'm a little woozy, so if the questioning doesn't make sense, please bear with me, Mr. Secretary. Mr. Secretary, I wanted to echo something first before my prepared remarks from my colleague, Mr. Blumenauer, in regards to hospice and palliative care. It's something I'm very passionate about. Actually, in my personal time, I'm a hospice volunteer here in D.C. So I would encourage you to consider one of the things I've been working with Charlie Dent from Pennsylvania on our side of the aisle in regards to advanced directive counseling as you enroll in Medicare, as you enroll in Medicaid. Not only do I think that's good, sound policy, I think also if you look at the bean counters here in D.C., they will give you a positive score effect in regards to savings that it has in the healthcare arena. I wanted to also welcome you and to share that I co-chair the Diabetes Caucus here in Washington, D.C. I'm a father of a type 1 diabetic, diagnosed at 4 and now 17. And so this is something near and dear to me, and I've worked with Diana DeGette on the other side of the aisle over the years in regards to her. She's co-chair of the Diabetes Caucus. And insulin pricing has been something we've been working on. And as in your former role, I'll note that the the QuickPen, I believe, is the Humalog QuickPen rose from $55 to $105 during your tenure in that private organization. And I would hope you could explain maybe a little bit as to why those prices went up, and maybe specifically what your intentions are as the Secretary of Health to help us try to get those insulin prices under control, going in the right direction, which I think we can share needs to go down, not up.
So, Congressman, I need to speak because of my recusals that are required as part of government ethics, I would need to speak broadly about what we intend to do around drug pricing. Of course, none of our efforts are targeted at any one sector or part of a therapeutic area.
Respect that.
The President's budget, I think, has some very important reforms in it that can help us, especially in the Medicare Medicaid context, because it's in the budget setting right now. But one thing, in addition to the proposals we have in the budget right now, we have been radically increasing the number of generic drug approvals. The highest number of generics ever approved in history were done under Dr. Gottlieb's leadership just last year. We've changed for senior citizens reimbursement rules that have led to a $3.2 billion reduction over 10 years in what senior citizens will pay out of pocket for their medicines. So those have already happened. I want to develop a very robust biosimilar market, which is the generic-like versions of these higher cost or injectable products. We want to build the scientific evidence base where eventually those might be interchangeable. We want to ensure that there's a viable commercial marketplace by supporting through our programs incentives to the utilization of those biosimilars, because that can long-term help pull the costs down and pull the out-of-pocket for our citizens down.
Truly appreciate that. Look forward to working with you, and welcome, Mr. Secretary.
Thank you. Dr. Davis, you're recognized.
Thank you very much, Mr. Chairman. Mr. Secretary, I was pleased to see that the budget included my proposal to triple funding for regional partnership grants. But I'm troubled that your war on health care will make it impossible for these community partnerships to be effective to help motivated parents get treatment and keep their children safe at home. Medicaid is the program that provides the vast majority of opioid abuse treatment, yet the Trump budget slashes $1.4 trillion from Medicaid and asks us to applaud a couple billion as a heroic effort. These Medicaid cuts would devastate millions of Illinoisans. Further, Illinois receives over $62 million from Social Services Block Grant, which provides critical support for over 139,000 Illinoisans. The Trump budget eradicates these funds that local communities are using to fight the opioid crisis, funds for child and adult protective services, substance abuse prevention and treatment, senior services, disability services, community health, and domestic violence prevention, yet it gives $29.2 billion to the wealthiest, fewest states. Mr. Secretary, I am deeply concerned about your department's proposal to delay 2 years the modernization of the child welfare data system. As you likely know, the final FCARS rule is the first update in 25 years. The final rule reflects the improvements agreed upon by the child welfare community as needed to improve policies and outcomes for foster youth. Importantly, the improvements apply multiple statutorily mandated upgrades, statutorily mandated improvements to prevent sex trafficking, to improve how Native American children in care are served, and to understand the physical and mental health needs of children in care. But HHS is blocking the implementation of this critical rule with vague justification of whether the proposed collection of information is necessary or burdensome. I wrote a letter to you this week with Senator Wyden expressing our deep concerns that your delays undermine our understanding of the needs of foster youth. My question, can I get your commitment to seriously look at rescinding the 2-year delay of the FCARS rule and implement the laws that have been passed?
So, Congressman, I'm glad you raised that to my attention. I was not aware of that issue, and so I will be very glad to look into that and get back to you on that.
Thank you very much. And Mr. Chairman, could I get permission to insert into the record a report by the SSBG Coalition related to how it protects families and communities affected by the opioid crisis?
Without objection, Dr. Davis.
Thank you.
Mr. Mean, you're recognized.
Thank you, Mr. Chairman. And Mr. Secretary, thank you for your service, and you bring a great deal of experience to this. I look forward to working with you, and I am pleased that you've identified a number of priorities. First and foremost among them, the concept of value-based payment as we transition away from a fee-for-service model. And it's clear to me that you're looking at a variety of things. And as a former United States attorney, I spent a lot of time working in the area of Stark and anti-kickback, and it had its purpose. There was no question about that. But we see opportunities for great new collaboration to take place if we can find the right safe harbors and other kinds of places in which we can incent this kind of activity to take place. Now, I know you've got a working group within your own agency, but I think you've got, as my colleague from Illinois said, you've got a lot of members here on a bipartisan basis that are anxious to work with you. I'd like to ask if you could lay out for us in communications with us, the plans for this group and how we can work almost simultaneously with you on legislation that can improve it. There's an interest in doing this, and I'd be happy to collaborate with whomever that you would identify. Second, I am grateful for the work you're doing on opioids. Part of the legislation we passed in before talked about one thing called the lock-in program, in which we are trying to do a better job with respect to the opioid prescribing and assuring that we monitor that better. It was a voluntary program. I think there's an effort now to try to make this mandatory. I would like to work with you on that as well, particularly with respect to incenting states to talk to each other. And lastly, I'm very appreciative as well of your recognition of a safe and secure effort to protect information for those who utilize the system, health records and other kinds of things. Internet of Things, cyber, we're seeing huge interconnectivity and huge challenges as well. I know that your cybersecurity task force is going to be looking at ways to do a better job of not only reaching across the broad governmental spectrum, but recognizing unique things like privacy and other things that are challenges. I once again want to articulate that we've got numbers of people here who are anxious to work with you on those issues and not to have us working in silos, so that the efforts that we can do can dovetail off the improvements that you can make. So I want to thank you for that, and look forward to working with you in the area of emergency preparedness as well. Just the last thing on Stark, I think that too, we're looking at physicians, but I think that there's things from medical devices to drugs, as you well know, and others that could be included in that dialogue. I hope you will consider that. Thank you, Mr. Chairman.
Thank you, Mr. Renacci. I know you had to step out for a budget hearing, but you were here when the hearing began. You're recognized.
Thank you, Mr. Chairman. I want to thank you, Secretary Azar, for being here to speak with us about the fiscal year budget. A few issues as important as personal as health care. I'm pleased to see that department budget reflects a significant focus on tackling the opioid epidemic. This epidemic has ravaged my state. The Ohio Department of Health reported that in 2016, 3,600 Ohioans died of the opioid overdose. It's encouraging to see that the administration is looking to partner with state and local governments in an effort to put an end with this crisis. For some time, much of the conversation about combating opioid epidemic seems to center on increasing access to treatment recovery services, a lot of times just about money. What I hear less about is addressing some of the root issues, like why are doctors prescribing high volumes of opioids in the first place and prescribing opioids versus pursuing other pain management practices. I can tell you personally, when I was 18 years old, I was in a motorcycle accident, hit a car at 55 miles an hour, went over the car, ended up 100 yards down the road, still went to school the next day with a bottle of aspirin. Did not have opioids back then. Or wasn't prescribing opioids. So some of the problems is our policies. And I'd like to hear in the proposed budget if we address some of those issues.
You bet. Thank you very much. And just to let you know, I actually just the other day spoke with Governor Kasich to get some of his insights about steps being taken in Ohio around the opioid crisis. We're going to be working with him to get some of the best practices and be sure that we can share that across the states, since you've been so much at the epicenter of it all. In terms of our budget, one of the things that we're proposing is to grant authority to suspend coverage and payment for drugs when those prescriptions present an imminent risk to patients or whenever they're prescribed by physicians who have been engaged in misprescribing or overprescribing drugs with abuse potential, so exactly what you were talking about. In addition, our proposal provides the Secretary with authority to require additional clinical information on certain Part D drug prescriptions, such as diagnosis and incident codes, as a condition of coverage so that we can better get at this problem.
Great. I was intrigued to see part of your budget proposal included $500 million for public-private partnerships to accelerate the development of strategies to prevent opioid abuse. Has HHS considered other programs in areas where the potential exists to leverage non-federal resources to make our dollars go further?
The main one has been the NIH program. I'm not aware of others, but obviously anytime we can leverage external dollars to assist us and stretch the federal dollars, especially on a crisis like this. So if you have ideas, I'd be very glad to hear them.
Appreciate that. Thank you, Mr. Chairman. I yield back.
Thank you. Ms. Sewell, you're recognized.
Thank you, Mr. Chairman. Due to the fact that we only have 3 minutes, I'd like to submit for the record questions that I have and hope that, Mr. Secretary, your office will give us some responses to that.
Without objection.
First of all, welcome, Secretary Azar. As you are aware, rural hospitals and providers across the country are struggling to maintain basic services and to keep their doors open. There are several rural hospitals in my district that struggle each month to pay staff. This is because my state, Alabama, has the lowest area wage index in the country and the most bare-bones Medicaid program, which reimburses some hospitals at 10% of costs. I'd like to join Representative Black in requesting that you look at the wage index. We both co-sponsor a wage index bill that all we're asking for is parity and some sort of equality. I think that the current model is really unsustainable, and I believe that our federal policies should be helping the delivery of Medicare and Medicaid to the most vulnerable in our society. If I sound frustrated, it's because I am. We have consistently asked rural hospitals to do less with more, to do more with less, sorry. And as a result, 83 rural hospitals have closed since 2010 across the country. Mr. Secretary, my home state of Alabama has one of the bare-bone Medicaid programs out there, and we didn't expand Medicaid. So there is a direct correlation, I believe, between hospital closures and states that did not expand Medicaid. Do you know what percentage of rural hospital closures since 2010 have happened in states that didn't expand Medicaid? I'll tell you, 76%. And 5 of those rural hospitals have been in my home state of Alabama. The President's budget ignores these facts by repealing the Medicaid expansion for states that have benefited. The proposed budget also cuts $1.4 trillion from the Medicaid program. Mr. Azar, Secretary Azar, if you are a parent in the state of Alabama, a family of 3 in Alabama who makes $10,000 a year, you do not qualify for Medicaid. Can you get any assistance for your own health insurance? And the answer to that is no, because they fall in that Medicaid gap. To qualify for Medicaid in Alabama as a parent of a family of 3, how much would you have to make a year to qualify for Medicaid? It's less than $4,000. So if you make anywhere between $4,000 and $10,000 or $21,000 in Alabama, you get no assistance for your health care coverage in my state of Alabama. I think this is unacceptable, and I really believe that our federal policies should help try to make sure that we level the playing field so that those that need Medicaid and Medicare can actually get access to it. So
Gentlelady's time has expired.
Thank you, sir.
And Mr. Secretary, if you would respond to the questions in writing by Ms. Sewell. Thank you, sir. Mr. Rice, you're recognized.
Thank you. Mr. Secretary, thank you for being here today. I join with Mrs. Sewell and Mr. Kind in our concern about the rural hospitals that have accelerated their closure since the advent of the Affordable Care Act, and hope that we can find ways to mediate the effects of the Affordable Care Act on our rural hospitals, because I've had 2 close in my district. But the thing that I hear when I go around my district the most, when people are talking to me about health care today, and in fact, I did a telephone town hall last night, and I had somebody ask me this direct question. They said, thank you very much for the tax cuts. It's made a difference in my budget. But the truth is that with the with the health insurance premium increases that we continually see under the Affordable Care Act, which should more aptly be named the Unaffordable Care Act, all of my tax refund has gone to these health insurance premiums. Last year, I know HHS put out a report that said the average premium under Obamacare from 2014 to 2017, 2014 when it came in place, till 2017 was 105%. This year, I haven't seen the numbers yet, but I know it's going to be astronomical. And the truth is that the average person simply cannot afford health care under the Unaffordable Care Act. You mentioned earlier a focus on trying to work to get health insurance premiums down. So what I'd like to know is your specific ideas on how HHS can help with that. And second, any specific legislative proposals that you might have for us to work on, given that we're stuck with the Affordable Care Act. What can we do within those confines to try to bring those premiums down, or at least slow the acceleration of the premiums and the deductibles?
Thank you, Congressman. As you know, the President's budget does propose a version of the Graham-Cassidy legislation that was in the Senate as a mechanism of creating a grant program to states that would be very flexible, would still have some core protections around pre-existing conditions, under age 26 for coverage of children, maternal care and newborn care, so some baseline core national protections, but then flexibility for states who would then be able to design their own systems that fit their needs and figure out ways to deal with risk pooling. How could you maybe peel off, as Alaska has done, your higher risk individuals, fund that and make sure that they're getting care, but then make insurance vastly more affordable for the rest of folks. I'm quite concerned. It's a deep and lifelong passion of mine around affordable insurance coverage for individuals. And what troubles me so much is that we have 28 million individuals who are out of that market, who are not able to afford access to individual insurance. And so we take that challenge very seriously of what can we do to make the system work better for them.
If you have any specific suggestions for legislation, I'd love to see them. Thank you, sir.
Thank you. Mr. Schweiker, you're recognized.
Thank you, Mr. Secretary. You've been on the job for 13 days? Okay, so by now you should know everything. Hey, I know this is a bit like a machine gun, but when you have 3 minutes, you sort of have to do it that way. Your current budget is 8.5% increase in spending each year for the next 10?
The Medicare budget would be 8.5% per year for Medicare.
Okay, yes. So that's the Medicare. So functionally, if you do the compounding on that, I mean, over 10 years, it's like doubling.
It's a lot of money, yes.
Doubling. So at some point, we're all going to have to, on the right and left, have to have a very honest conversation about doubling that budget over the next decade is a stunning amount of money and terrifying. I know you put Graham-Cassidy mechanisms in your budget. Parts of it we like, some parts I mathematically am concerned with. I don't think you actually get the multiplier efficiency. The state experiments are wonderful, but if we're dealing with a mathematical reality, particularly in the individual market, that 5% of the population is 50% of the cost, risk sharing, as you, I think, have actually spoken about, when you mitigate risk here, I lower the premium here, I lower the subsidy. If I lower the subsidy, I can put that up here and buy down more risk. Well, then I lowered the premium, I lowered the subsidy. There is this virtual circle because we subsidize both at this level and this level. You could actually bring them into parity and create this virtual circle if you can lower the premiums by finding a way to do that risk mitigation. Yes. And I hope you're going to model that feedback loop, because I think there's a much more direct and much more elegant way for rate efficiency than sort of the convoluted mechanisms that we as politicians have a bad habit of thinking about. My single biggest passion for you, as you've probably already found out, you're where a lot of the money is. And you have group after group after group that are at your doorstep not wanting you to affect their business model. The Economist magazine 2 weeks ago wrote a powerful article that technology, that this is about to become my primary care physician. The technology of wearables, the ability to manage my health care. You are the single individual who has the power
to create the revolution of bringing technology into crashing prices, everything from pharmaceuticals to healthcare to emergency room visits. I beg of you, innovation, technology, push it as hard and aggressively as you can, and you're going to have a lot of folks at your doorstep who are terrified because you're blowing up their business model. But how many times did you go to Blockbuster Video this weekend? Right. Things change. With that, Mr. Chairman, I yield back.
Gentleman yields back. Ms. Sanchez, you're recognized.
Thank you, Mr. Chairman. Mr. Secretary, thank you for being here, but I have to say that, frankly, this budget is a disgrace to the working people of this country. I would be hard-pressed to come up with a budget that's more out of touch with the needs and concerns of everyday people than this budget. The people that I represent and the families that I hear from every day would suffer greatly under the massive cuts in this proposal. I think about single parents. I think about women who have to work to support their families while caring for children and perhaps aging family members at the same time. And this budget really hits them where it hurts. It makes it harder for parents to work and to feed their children by slashing funding for necessities, not luxuries, but necessities like housing, family planning, and food. It puts their health and their lives at risk by jeopardizing and undermining their access to affordable, quality health insurance. And it will not reverse the steep decline in families receiving help with child care. And to those who care for a loved one with disabilities or a parent who needs nursing home care and is covered by Medicaid, this administration basically says, good luck, you're on your own. And if the very, very worst happens, you get sick and you can't work, or your child or parent does and you need to take time off to care for them, this administration wouldn't let you have paid leave for that. So good luck paying your bills, caring for your family, and dealing with serious illnesses like cancer or Alzheimer's. That's completely on the shoulders of those families. It's absurd and it's cruel. Families back home don't want us to make their lives harder. It's hard enough as it is for them to get by. And putting health care and nutrition assistance further out of reach only makes things worse and will make it that much harder for people to work. We were not sent here to make things more difficult for those hardworking families. Our purpose here is to try to improve the quality of people's lives and give them a fair shot and a fighting chance. And quite frankly, this budget fails the most basic test. And I'm sorry to unload that on you. I know you're new to the job, but honestly, I'm shocked and I'm quite frankly appalled that this is, quote unquote, the best we can do, because we can do better. We're a powerful country. We're a generous country, generosity of spirit of the American people, but we're not seeing this budget champion the middle class that this president promised he would be a champion for. And I sit here and I scratch my head because I wait and wait and wait for the follow-through on those promises, and that never comes. And with that, I yield back.
Gentlelady yields back. Ms. Walorski, you're recognized.
Thank you, Mr. Chairman. And Mr. Secretary, my fellow Hoosier, it's good to see you. Welcome. I wanted to add my yes and amen to my colleagues, Representative Paulson's comments about opioids, non-opioids, alternatives, getting insurance companies to be able to cover these things, and I've already heard you out. For the sake of time, I wanted to mention one other thing that I look forward to discussing with you. The budget process, the budget proposes reforming Medicare payments related to bad debts. I have a piece of legislation, H.R. 3920, that would require CMS to implement a 3-year demonstration program to study the use of interest-free payments under Medicare Part A. I have a hospital in my district that has implemented this concept of interest-free payments and have seen improved patient satisfaction, improved health outcomes, and a reduction in bad debts. Is that something you're willing to work with, interest in, trying to come up with that kind of a model?
Sure, I'd be happy to learn more about that. I had not been familiar with that model.
And my other question is this. A group of doctors in my district have expressed to me the need to fund the National All Schedules Prescription Electronic Reporting. It's called NASPR. program. They feel this program provides them with a complete past medical history regarding prescriptions on controlled substances. While state PDMPs are important, they have trouble with a group of patients that either live across a border in Michigan or they're around the entire U.S. for various reasons. Having up-to-date patient information would empower providers to deny inappropriate treatments or recommend addiction treatments to be started based on what they discover. Does funding NASPR help provide funding resources or interoperability between these PDMPs so providers better identify patients at risk for addiction, especially those patients who do not live within a state's border? Do you have any other suggestions on how you think we can empower providers to identify at-risk patients?
So the budget actually does propose requiring the state prescription drug monitoring programs, and I believe there may be something, I want to get back to you on this around the interoperability across state lines, because that is a vital issue, and I just cannot remember, but I think there's something in our budget about that.
Thanks. Thank you so much, Mr. Chairman. I yield back.
Thank you, gentlelady yields back. Mr. Corbello, you're recognized.
Thank you, Mr. Chairman, and thank you very much, Mr. Secretary, for your testimony and for all your time with us this morning. The opioid crisis, which we've already heard discussed so much this morning on both sides of the aisle, because I think everyone is deeply concerned about it, certainly has hit South Florida. And the budget requests authority to work with the Drug Enforcement Administration to revoke provider certificate, which allows a provider to prescribe controlled substances. How does the process work now, and how would this authority help the Secretary, your office, combat the opioid epidemic?
So if we were given this authority, this would enable us, whenever we ban a provider within the Medicare system, to immediately transfer that information over to the DEA so that they could also ban them from the controlled substances prescribing system, where now there are barriers basically to even communication sometimes on that. This would make it automatic that it could go over in DEA and we could be in sync around banning providers, so that when we identify a pill writer, a pill mill, it goes right over and their license is cut off on that side also.
So you think this would be an important tool that could help you make a difference when it comes to this crisis? I want to take you over to the other side of the House, the Human Services, and I've been fortunate to work on this committee with Dr. Davis, Congressman Davis, on a legislation called Accelerating Individuals into the Workforce Act. And essentially what we're trying to do is encourage people to move from many of the government assistance programs we have into the workforce, become empowered, become independent, and really achieve their own success, whatever that happens to be. What is your vision for your collaboration with the Department of Labor, for example, on these programs, with how you can help us in our goals, I think bipartisan in nature for the most part, to help individuals move into the workforce and become better citizens?
I'm glad you asked that question. So one of the proposals we have in our budget is called Welfare to Work, which within our own programs within the Administration for Children and Families, it would enable us to create a holistic set of programs around the individual. You know, we've attacked different problems that individuals in need would have. This would let us build aid for them and a transition to work around the individual. And my vision would be, once we can prove that that works well, I want to work with labor and HUD and all the other participants in human services to see if we can help build this type of holistic approach to individuals rather than our old siloed ways of getting at these challenges. And then we're also working in the budget to shore up our temporary assistance for needy families programs to genuinely have accountability for the states to get people trained and out there working.
Well, I appreciate that, and my goal is not to cut any of these programs, it's to reform them so that they're more effective and they actually help people more. Thank you, Mr. Chairman. I yield back.
Thank you, gentleman. Yields back. Ms. Chu, you're recognized.
Secretary Azar, given my limited time, I would like to ask you a yes or no question. Do you believe that the policy staff at the Department of Health and Human Services should be responsible for writing all department policy?
We don't have a single policy staff. We've got policy experts throughout the 300 programs of the department.
But they are policy staff within the department.
We have individuals, I don't know that they're generally even called policy staff. I'm just not, I don't mean to be difficult, it's just not a categorization that I'm familiar with within the department. Just, we have staff, career, and political professionals.
Well, thank you. I ask because the ranking member of the House Oversight and Government Reform Committee, Elijah Cummings, announced on Monday that an HHS whistleblower has delivered evidence that the original author of a CMS letter to state Medicaid directors was not someone within the agency, but a representative from the Alliance Defending Freedom, an extremist religious group that the Southern Poverty Law Center has designated as a hate group. According to the whistleblower's documents, on January 11th, HHS received a draft letter from ADF, the hate group. That same day, the department's, the deputy's HHS Secretary's Chief of Staff sent an email to CMS, and I will quote her email here. It said, quote, CMS should be receiving the SMD or State Medicaid Director letter today. Please make sure that your clearance process is ready to go on this. We will need a very quick turnaround. Consider an utmost priority, unquote. Given the timing of the emails and when HHS received this draft letter from the hate group, it appears to Ranking Member Cummings and to myself that the HHS was, quote, taking orders from outside groups in order to write policy. I'm extremely concerned about the idea of a hate group drafting official U.S. government policy. Furthermore, the policy in question encourages states to defund Planned Parenthood, which provides health care to millions of American families. This is yet another example of this administration siding with religious extremists over the health of women and families in this country. President Trump's budget is no exception. After repeated attempts to defund Planned Parenthood failed in Congress last year, the Trump administration has taken it upon itself to attempt to do so administratively. I'd like to remind you, Secretary, that this committee, that the Planned Parenthood health centers provide essential health care services like cancer screenings, STD testing, prenatal consultation, and contraception. At every turn, this budget is a bad deal for women, and Secretary Azar, I strongly encourage you to reconsider your agency's association with hate groups as you move forward and to work to improve the health of families and women, not undermine it. I yield back.
Gentlelady yields back. Mr. Bishop, you're recognized.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here, for your patience, for being with us and providing your testimony. I guess I want to first say to you that I appreciate the priorities that you laid out in your opening statement, addressing the opioid crisis, reducing the burdensome cost of prescription drugs, making health insurance affordable and accessible, and improving the quality of the Medicare program. Laudable, important priorities for the department, and we appreciate that. I don't have much time, so I guess I'd like to, if I could, address what's a major concern for all of us, and that is the opioid epidemic. My colleague, Mr. Curbelo, asked a question that earlier about the DEA, and I wonder if you might be able to clarify a little bit of your request on the DEA to curb the volume of prescribed controlled substances. I'd like to hear more about that. I'd like to hear about what's currently being done and how this might enhance your ability to help us address that issue.
So thank you. I'm still learning even the extensive operations of the connectivity between HHS and DEA on this front with regard to the opioid crisis. You put your finger, though, on what I think is one of the first of the three big elements that we've got to get at, which is the prescribing of legal opioids that get people started down this pathway. And we've got to find alternative pain management tactics. That's where CDC guidance can be so helpful to steer our providers away from opioids to the best other pain management treatments. We've got to look at issues of state regulation of pharmacy around just how many pills are people getting, which physicians can give those pills to individuals. So I really want to focus on that entry point to working with DEA on ways that we can control pill mills and even just bad practice that has become part of our culture of medicine of giving people excessive numbers of pills or opioids when they do not need them.
Mm-hmm. Each one of us engage our community in some way, shape, or form, in whether it's a town hall meeting or just a session with professionals to talk with parents about the issue of the opioid crisis. I'd really like to know from your perspective, are there resources that you can provide us to help us with that process of educating parents, educating communities as to the extent to which this opioid crisis exists and whether or not there are ways in which we can all be involved in addressing the crisis.
There are, and in fact, we'd be very happy through our Substance Abuse and Mental Health Services Agency to get you any information there to help as you do town halls or other meetings. This crisis is so devastating. It is a there but for the grace of God go I or any family in this country, because someone can slip into addiction so easily off of the legal opioids and fall quickly down this pathway into the illegal opioids and then into treatment and relapse, death, and overdose. It is a devastating crisis. We are going to be working to educate the country more through our budget also.
Thank you, sir.
Thank you. Mr. LaHood, you're recognized.
Thank you, Mr. Chairman, and welcome, Mr. Secretary. And when we look at your background and experience, I don't think there's anybody more well-suited for this job or qualified for this job, particularly your work in the private sector, your prior work at HHS, and your legal background. And obviously your Midwestern common sense is a benefit also. So we wish you much success. Mr. Secretary, I know several of my colleagues have brought up concerns about access and quality in rural areas, and I represent a rural area in central and west central Illinois. Particularly on that subject, can you elaborate on priorities in the budget, specifically to fight the opioid crisis in our rural areas?
Could you grab the microphone there, Mr. Secretary?
Thank you very much, Mr. Chairman. As part of the budget proposal and through the Bipartisan Budget Act last week, we now have $10 billion that we have asked for funding in 2019. Of that, we're going to now have through SAMHSA $1 billion going out for state targeted response grants. So that's a doubling of the money that was going to states even in the last 2 years under CARA. So $1 billion going to states there that will really help in a rural setting. We also are going to be increasing money to help local communities and first responders buy naloxone, which is the overdose medicine. And then we have another program that we're going to be funding that is actually targeted towards our rural communities and best treatment practices and care, and that's also coming through this budget request very much around we understand the real difficulties in the rural communities around access to treatment facilities and treatment programs.
Well, we look forward to working with you on that. Switching subjects, I want to talk a little bit about regulatory reform. We continue to be impressed with this administration's fight against unnecessary and burdensome regulations in the Medicare space. As we move towards a more data-centric healthcare model, challenges in the transition from fee-for-service to value-based reimbursement continues to be filled with regulatory challenges for physicians. Can I get a commitment from you and your team that you'll continue to identify ways to streamline this transition process and work with Congress on unwinding some of those regulatory burdens?
Absolutely. In fact, we have a whole series of workshops that we've had about decreasing burden on providers and physicians as they interact with their patients to make sure that they can spend their time working with the patient and not with us.
Yeah, well, we appreciate the work thus far and look forward to continuing to work with you on that and your commitment.
Thank you.
Thank you, Mr. Secretary. I yield back.
Gentleman yields back. Mr. Higgins, you're recognized.
Thank you, Mr. Chairman, and thank you, sir, for being here. The healthcare industry in America is a $3.4 trillion annual industry. Health insurance and health care is all about quality and costs. I think based on any objective measure, we're not achieving optimal results. I think everybody agrees with that. But I think like anything else, you know, the federal government is a massive purchaser of health care. Not only general services, but prescription drugs as well. You've got 74 million under the Medicaid program, which is an insurance program. You've got 57 million people under the Medicare program, which is an insurance program. You've got 30 million under the Veterans Administration. That's a lot of leverage. That is a lot of leverage to drive down the cost of health care and drive up the quality, insisting on it as a major consumer of health care. People on this committee and in this House, we can disagree, and we do, Republicans and Democrats, about the extent to which the federal government should be involved in health care. But one thing we know is we will be involved. So while we're involved, let's use that leverage. I have a bill with some other members which would allow individuals to opt in at their own cost into the Medicare program at age 50 to 64. showing a 40% savings each and every year when compared to another plan on a gold plan on the exchanges. Again, that's using the leverage. Because every healthcare reform issue that we see, that population between 50 and 64 gets clobbered with huge premiums and very little underlying health care for a very simple reason. Insurance companies don't want to write a policy for people that are older and sicker, statistically. So they jack up the premiums, jack up the copays, jack up everything, and those people are uninsurable. It is, to this century, what the Medicare population was to the 20th century. So we need to do a better job with that. Finally, you come from the pharmaceutical industry, and you obviously know that that's a big challenge for us relative to costs. The Medicaid program, the Department of Defense, and the Veterans Administration all authorize negotiated discounts with the drug makers. According to the Commonwealth Foundation, each of those organizations experience nearly 25% savings each and every year by negotiating volume discounts. Why in God's name are we not allowing Medicare to negotiate volume discounts to achieve those savings?
And I certainly agree. As we look at Part B, for instance, we have no negotiation there, and we've got to look at ways to introduce competition and negotiation into Part B.
Thank you. Gentleman's time, excuse me, has expired. Ms. Nome, you're recognized.
Thank you, Mr. Chairman, and thank you, Mr. Secretary, for being here today. I want to change the topic a little bit and go outside of this committee's jurisdiction and talk about Indian Health Services. You do have a lot of opportunities to improve the kind of services that our tribal communities are receiving today. As you know, thousands of my constituents in South Dakota are served by this agency, and they're getting third world quality health care right now. In fact, people are dying because this agency is such a disaster. We have babies being born on the floor, surgical instruments that are being washed by hand. We have doctors and nurses and healthcare providers on drugs. Administrators aren't doing their jobs. And unfortunately, even though several of these facilities have been under review by CMS and even facilities closed by CMS, we haven't gotten any better. What happened was that the direct service facilities in South Dakota that have been cited by CMS for poor care, and the Pine Ridge Hospital lost CMS accreditation for a period of time. The loss came even after CMS and IHS partnered together to provide more quality tools and access to the hospital engagement network and other telehealth capabilities. So it's so bad in South Dakota and in the Great Plains region that tribes in neighboring Nebraska have been fed up and are waiting for IHS to fix their hospital, which has been without CMS accreditation since 2015. They've started to take over their hospitals themselves. My tribes are too poor to do that. They don't have the resources or the dollars to do it, and it's an emergency situation. As many as 9 of my constituents have died in ambulances traveling to other facilities over 50 miles away because the other facilities were closed because of such poor quality care, and people continue to suffer and die because of this inadequate leadership. I'm pleased that more dollars have come into IHS. In fact, since 2011, we've increased funding for IHS in Congress, but that doesn't mean it's getting any better. So we can't keep throwing money at a problem that's not getting fixed, and we need a plan for success. I'm wondering, Mr. Secretary, if you're aware of how bad it is and what you're going to do about it.
So thank you for raising the important issues, especially about the South Dakota and Great Plains facilities. I'm very aware of it. We're very focused on it. And in fact, we prioritize that in the budget. I'm delighted that with the budget proposal, we're requesting an additional $413 million for the Indian Health Service.
You know more money is not going to fix this.
Well, and $58 million of it, plus 29, is actually directed just towards these accreditation and safety issues on the Great Plains and these other hospitals. So that's a major focus for us. CMS is deeply committed to trying to help work with IHS to bring the quality of those facilities up to snuff, and that targeted investment will help. We also need to ensure that we've got the right people. It's, of course, very difficult to recruit and retain at some of these facilities, and so look forward to working with you if there are any additional flexibilities that we would need to enable that to be possible.
So I have a piece of legislation that's pretty comprehensive, but I've been working with your staff on this, and I'd love to have your help. It's Restoring Accountability to the IHS Act. If you would look at it, I need your help. Thank you. I yield back.
Great. Gentlelady yields back. Ms. Delbene, you recognize.
Thank you, Mr. Chair. Thank you, Mr. Secretary, for being here with us. In your opening statement, you called the NIH a crown jewel of American science and that it's a priority. And I agree with you. I have concerns, though, with the budget here, and just if you could give me some quick answers, since we don't have a lot of time. It's my understanding that the administration is touting a $1.4 billion increase in NIH funding in FY19. Is that correct?
The total is $34.8 billion plus $750 million of opioids. So I think the total add would be about $1.5 billion, if I remember, off of the CR.
Okay, so the opioid number, that 750, is something new and a new responsibility. So that's not an increase of the existing budget of NIH based on their current responsibility. That's giving them something new and dollars for something
Well, no,
new.
they're very focused. I mean, opioid and pain, addiction treatment, that's all part of the core mission of NIH already. This is additional funding for them.
And then it's just not assigned to any institute, so it's kind of, it's out there, so it's
It'll
unclear
enable the
where it's
director
going.
actually to prioritize, which I think is the best way to do it, that kind of flexibility.
Also, the increase seems to include $255 million for occupational safety research that's currently at the CDC, so that would be moved over from the CDC, is that correct?
That's right. The National Institute of Occupational Safety and Health, we believe that its research mission best aligns with NIH and then can be part of that. I think a lot of synergies there for working together.
I'm just, I don't have a lot of time, so I just want to make sure I get through all this. The moving that over, that actually has an existing budget, so you're moving that over to the NIH, but that's also part of this increase, but it's not really an increase. You're just moving it from the CDC over. And then there is also $380 million for healthcare quality research that's currently at HHS that is also proposed to move to NIH. Again, isn't that something that would be moved over that has an existing budget you're just putting under NIH now?
And the Agency for Healthcare Quality Research also does move over as part of the budget proposal.
So really, when we talk about the budget, and I just want to be clear, these are the numbers that we have. The National Cancer Institute budget decrease, National Heart, Lung, and Blood Institute decrease, National Institute of Dental and Craniofacial Research, a decrease in funding, National Institute of Allergy and Infectious Diseases, a decrease. Most of the national institutes actually see a decrease in funding, and some of the numbers that you have here actually just are movements of responsibilities that were in other parts of HHS, moving them to NIH. So if we're really going to talk about NIH being a priority and increasing its budget, which I agree with, I don't think this does that at all. And so I hope we'll be really straightforward about the numbers going forward and prioritize the research at NIH. I yield back.
Thank you. Mr. Keller, you're recognized.
Thank you, Chairman. Mr. Secretary, thanks for being here. Congratulations on your appointment, and certainly we appreciate your willingness to serve. It just seems sometimes we operate in a situation where people put themselves forward because they're patriotic, and they go through an awful lot to do that. My concern, and I think you're aware of it already, there's a transition to a single accreditation system in the GME, and it's going to have a negative impact on smaller medical residency programs. I have very strong concerns that there will be only one accreditor responsible for determining which programs are approved to receive over $15 billion in taxpayer funding each year. The Lake Erie College of Medicine, or LECOM, which is in the district that I represent, is the largest medical school in the country, and there's certainly other programs in the same district. They're going to be forced to change their business model or close, which many are already doing. So I know your department's looking at the impact on the closure of these programs, especially in the smaller and the rural communities that it's going to have on addressing the physician shortages. So any attention you can give to that, because this has become so critical. And I know that we always have the clash of the titans of who gets what and who determines who gets what, but this idea of the shortage of physicians, LECOM has done such a tremendous job in investing in the future of our country by getting these people prepared to serve. I just hope that we'll take a long look at that and make sure that we're being equitable and we're making sure that these schools can actually stay open. So any attention you can give to that is great. The other thing, everybody's talked about the opioid crisis, and I don't know that you need any more information about that. There's certainly not a person in this room or in this country that has not been touched personally or is not in contact with somebody who's been touched personally with this. I thought the President early on said that, we have to find a way to have non-addictive painkillers out there. It's absolutely critical. So anything that you can do in that measure would be deeply appreciated. It's quite a service, again, for what you're doing, what you're giving up to serve. I can't tell you how much I appreciate that. Thank you, and thanks for being here today. Mr. Chairman, I yield back.
Thank you. The gentleman yields back. I'd like to thank Secretary Azar for being with us today. So please be advised that members of Congress on the committee have 2 weeks to submit written questions to be answered. Later in writing, those questions and your answers will be made part of the formal hearing record. Ms. Secretary, your focus priorities on affordable and quality health care, making sure programs like Medicare work better and last longer, and addressing the opioid crisis are right on target. With that, the committee stands adjourned.